Sure. I'm going to be talking about the HCRN GU16-260 trial, which is a trial for patients with treatment-naive kidney cancer who got nivo monotherapy as their initial therapy, and if they had progressive disease or stable disease at 48 weeks, they were eligible to potentially receive nivo-ipi salvage. And I first presented the clinical data at regular ASCO in 2020, and now I'm presenting the updated clinical data as well as the PD-L1 biomarker data. And so the interesting results, we enrolled 123 patients, and the overall response rate for the group to nivo monotherapy was a little over 34%. In the favorable risk group, the response rate was 57%, with 20 out of 35 favorable risk patients responding. 17 out of those 20 responders remaining progression-free to this date, and only one of the 35 patients who were treated having early disease progression at the first scan. So that was a pretty impressive finding that suggests that favorable risk patients are probably more responsive to immunotherapy than we have thought based on second-line studies, limited first-line studies, and comparisons to targeted therapy rather than just looking at the immunotherapy itself. In contrast, patients with intermediate and favorable risk had response rates in the 25 to 30% range, which was probably less than what you would see with nivo-ipi, suggesting that for patients who probably can tolerate ipi, they should probably be getting nivo-ipi as their first therapy rather than just getting single agent, especially because we weren't able to salvage many of those patients with the boost. The response rate was only 11% to nivo-ipi boost, and only about 40% of patients who progressed on nivo monotherapy were actually able to receive nivo-ipi salvage because of issues related to toxicity on nivo monotherapy or symptomatic progressive disease that made it probably impractical or not in the patient's best interest to give them more immunotherapy, or because the study design where we wanted to have a biopsy to confirm metastatic disease and also do biomarker studies, and many patients couldn't actually have that biopsy done. The other important point of the study was that PD-L1 was actually a very useful biomarker from a standpoint of predicting PFS and response. That the response rates were more than twice as high in patients who had high PD-L1 than those who didn't, and the one-year PFS was significantly better for the patients with PD-L1 high than those with PD-L1 zero. And so PD-L1 is a biomarker that associates with benefit. Unfortunately, it's not that clinically useful because still 60% of the responders were in the PD-L1 negative group, because the PD-L1 positive group only represented about 20% of the total population. But it seems like it could be an important component of a biomarker study, and I think that it probably means that we can actually look at what's associated with PD-L1 in tumors and try to develop a biomarker that builds on this. And then I think it also highlights some of the flaws in all the previous biomarker studies where patients samples were used that were from the primary when you were treating metastatic disease. They were more than 12 months old. And there was an intervening treatment. They were looking at endpoints which were not typical endpoints for immune therapy, such as median PFS as opposed to landmark PFS or landmark overall survival. They were using combinations that didn't isolate out the activity of the PD-1 pathway blocking component, and they were comparing with a non-immunotherapy control arm instead of within the immunotherapy for benefit. And the HCRN GU16-260 trial got around all of those particular flaws, and that's probably why we're seeing the association that we saw.